Right. Okay. Good afternoon to you all. Right. So, welcome you guys for this new lecture series in ERPM obstetrics and gynecology. So, I would be grateful if you all can switch on your cameras and focus on your lovely faces. So then I can interact with you all. Don't worry, I'm not going to ask any questions from you all. So, right. Thank you. Still some people they want to hide their faces. Okay, thank you. Now people are coming, so it's going to be more live now, right? Okay, so my name is, first of all, I would like to give a brief introduction about myself. I'm Dr. Wasantha De Silva. I'm one of the VOG and one of the good old days ERPM teacher. I have been in this field more than now 8 years, I suppose. Yes. Okay, right. So from today onwards, I'm going to conduct several free classes regarding ERPM, obstetrics and gynecology theory, because I hope all of you all are now first time for the facing for the exam, for the theory exam. Okay, so to give us support and to give some guidance about the theory exam, I'm going to conduct these free classes for you all. So those who wants to join, you can join and you can share this knowledge with your friends as well. So as you all know, when you take the ERPM exam, initially you have to face this theory exam. Theory exam, when you take obs and gynae, you have theory paper with MCQs and SBS. Right? There are 25 MCQs, 25 SBS, right? So you have to get 45 marks out of 100 in order for you all to get the qualification to sit for the next part, that is the practical exam. So when you take the ERPM exam, especially when you take the obstetrics and gynecology, now you have, I know that you have 6 or 7 subjects to complete within a short period of time. You have about 3-4 months to go, sometimes even less than that. Within that period, you have to do medicine, you have to do surgery, pediatrics, obs and gynae, psychiatry, community medicine, likewise, lots of things you have to do. So this is a battle with time. Within a limited time, you have to achieve the expected level of knowledge. When you take obs and gynae compared to other subjects, the quantity wise is relatively small. Okay, if you weigh the subject, say for example, if you take medicine and obs and gynae, medicine, the weight of the medicine may be in kilos, say 10 kilos. But if you take obs and gynae, it may be 5 kilos or sometimes 6 kilos. Almost the half of that, the quantity wise. But when you take the quality or the content or the gravity of this subject is, I think it's the major part which determine in your exam. For example, in short and sweet, most of the students find it difficult with passing obs and gynae compared to the other subjects. Why it is so? What is the reason? There are several reasons. One of the reason is obs and gynae, you won't get like the subject wise. I told you the content is small, but the quality, or you get lots of new knowledge with this subject. Most of the people believe that if you say obs and gynae, you're doing obs and gynae, it's nothing, no, right? So obs and gynae, you can cover. People think we are dealing below umbilicus. This is the area of obs and gynae. You can cover with a small pant. Is that so? No. Even though this is the area of interest, you have to deal with the full body. The endocrine, physiology, everything will come under this. Okay? So lots of new knowledge, new terminology will be coming with this subject. So unless you are familiar with these things, it's going to be really difficult. And time to time, in the ERPM exam history, obs and gynae is going to be the rate limiting factor, because most of the students find it difficult with this subject. Because one thing is the subject wise also it's more deeper. Other thing is people spend less attention on the subject. So some people try to collect everything within a short period of time, like, when the exam date is fixed, then they are going to collect the knowledge and paste. That won't work with obs and gynae. If you all want to pass obs and gynae, my advice is, as a ERPM teacher for a long time, my advice is you have to pay equal attention on this subject as well. You have to be in touch with the subject from the beginning. Otherwise, Darwani, if you all plan to pass the exam at the last minute, last point, then that is too late. I will make sure, if you all are following these lecture series, right, and you will get the adequate knowledge for your exam. If you take the syllabus of obs and gynae, okay, it's again, if you go deeper, it's a vast subject. But your ultimate goal is to become a house officer, not a consultant, not a registrar, not a senior registrar. You need to become a house officer first of all. Then only, if you are interested, you can do postgraduate exams and all, you can become a consultant or somebody. So during this time, what you have to know is the basic things. If you try to study this subject in and out in greater detail within this short period of time, you will be running short of time, right? You don't have that time. And you can't remember all this stuff in your brain because you don't have only these obs and gynae to pass. You have so many other subjects also you need to study. So what I'm going to tell you all is that only the necessary stuff for your exam. So please believe me, right? At the end of this series, this lecture series, right, I will make sure you have the adequate necessary knowledge for your exam. Okay, right? And you will be given a very comprehensive lecture note, and at the end we'll be doing topic wise. We will revise the syllabus again with questions in topic wise manner, and we will do mixed revisions, and we will do past papers. And with all these things, you will be a fully armed person as far as the obs and gynae is concerned at the end of this exercise. Okay, without spending much time, shall we move on to the topic today? So as a beginning, I thought of doing this topic, that is infections in obstetrics and gynecology. Over last 2 years or sometimes 3 years, people were talking about these infections because of the corona business. You and me and everybody affected with this infection. So today what I'm going to teach all is infections, main infections related to these obstetrics and gynecology. As an obstetric student, as a gynecologist student, what are the infections that you have to know? What are the microbiological aspect? What is their clinical aspect? What are their complications? And what are the treatment options available? You have to know in and out about these infections, because some people spend less attention on this topic thinking that infection is not a major issue. No. If you analyze your ERPM past papers, you will get at least 2 or 3 questions from infections or related to infections. Okay, there may be MCQs, definitely you will get some MCQs as well as SBS as well. Single best type of the questions. Okay, Darwani. So I'm going to cover most of the important infections as far as the ONG is concerned within this short time. Okay, and very comprehensive note will be uploaded, and I think it has been already done. So you all can download it and you can go through the lecture note leisurely. And another last advice is that once we do a lecture or once you follow a lecture, right, when you go home, when you have a leisure time within 2-3 days period, please revise that topic again. Say, for example, once we complete infections today, today itself, or even tomorrow or day after tomorrow, please read that lecture note at least once or twice, then those things will be registered in your brain. Okay, right. So to begin with, we will start with syphilis. All right. Let me share this screen with you all. Yes. I think, can you all see this screen? Yes. Okay, right. Okay, right. So if you all have any problem with the setup and all, please let me know, right? So first we are going to discuss about syphilis, right? So you would have heard of this infection. Sometimes you would have seen the complications and all, but we will discuss. So first I will discuss about the basic information about this infection, mainly the biological part, mainly the microbiological part of this infection. If you take syphilis, syphilis is caused by this organism. This is called Treponema pallidum. Is it a bacteria? Sanchanan. No, it is not a bacteria. Is it a virus, Kasun? No, it's not a virus also. Right? What is this? This is called a spirochete. It's bigger than, larger than a usual bacteria. It's called a spirochete. You can see the spirals, right? So this is a spirochete, right? And when an infection enters into your body, there's a thing called incubation period. Incubation. For any infection which causes diseases in our body, there's an incubation period. What do you all mean by incubation period? The moment when the virus or the bacteria or the protozoa, whoever the person, germ, entered into your body, soon after that, they can't make us ill. To cause the illness, it takes some time. Some people may take days. Some people may take weeks. Some infection may take months to develop the symptoms and signs. That is called incubation period. Okay, what is the incubation period then? After entering the infection, to develop the symptoms and signs of the disease, that time period is called incubation period. For any infection, you have incubation period. Okay, Darwani? Right. So, how do you get this infection of syphilis? You all know that this infection is sexually transmitted infection. Sexually transmitted infection. What do you all mean by that? If somebody is having this infection, if he or she get in contact with another person, that person can transmit this infection to that person through the genital route. Okay, Ayesha? And through the genital route, you can transmit this infection to another person. That's called sexually transmitted infection. Okay, so this is purely transmitted by sexual contact, either homosexual or heterosexual or some other means. Sexual anyway. Anyhow, it's sexual contact, by sexual contact. Right. So when the organism entered into your body, Darwani, first of all, it causes a disease of syphilis, and in various stages. Stage 1, stage 2, stage 3, something like that. So stage 1 means once the infection enters into your body, it causes, after the incubation period, it causes a single painless ulcer. Remember, these are characteristic features of this infection. Now you all know that when you have an ulcer or a wound, what does it causes? Pain. Always when there's an ulcer, it causes pain. But what is the characteristic feature of syphilis infection? First sign is called painless single ulcer. A painless single ulcer. So once the infections entered into your body, okay, After about 6 weeks, up to about 6 months period, up to about 6 weeks period, you will get this painless single ulcer in and around the genital area. On the picture on the left hand, you can see on a male, right hand, you can see on a female. So what happens? When there is an ulcer or something which causes pain, the people tend to seek medical advices, isn't it? But when you don't have a pain, do you normally go and meet a doctor or get medical advices? No. So this infection may pass unnoticed because there is no pain. If there is no pain, why the HELL? You are worried about this thing. That's how people think. What is HELL? Yes. Right? So they don't take medical advice, and this infection, this is called a primary syphilis. Primary syphilis, after some time, it can go into what is called the second stage, that is called the secondary syphilis. That can go into what's called secondary syphilis. After about 6 weeks, after about 6 months, you can get secondary syphilis. When it comes to the secondary syphilis, Darwane, you will get this rash all over the body. There is a generalized skin rash, macular, papular skin rash all over the body. This is called condylomata lata. This single painless ulcer is called chancre. Chancre. Chancre means the primary syphilis. Primary syphilis. When it comes to the secondary stage, that is called condylomata lata. Condylomata lata. Okay? It's a good name for a newborn baby. Condylomata lata. You can Chinese it again. Condylomata lata means it's a secondary syphilis. You will get lymphadenopathy. You can get this generalized skin rash all over the body. Normally, when you have primary syphilis, it is infectious. Infectious means you can transmit this infection to another person. Primary syphilis. When it comes to the secondary stage, usually it is not infectious. That means if I am having the infection, I am there. It is there in my body, but I can't transmit that infection to another person. Not infectious. When it comes to the secondary stage, this stage. But it can damage your own body, but you can't transmit that to another person. That is secondary syphilis. Okay. So that is up to about 6 months, you get this secondary syphilis. Up to about 6 months. After 6 months period, this disease will be temporary, going into sleeping state. That is called latent syphilis. Right? Syphilis is there in the body, but they don't show much signs and symptoms after about 2 years. Up to about 2 years, after 6 months. That is called latent syphilis. You have primary syphilis up to 6 weeks, secondary syphilis up to 6 months, and latent syphilis afterwards up to about 2 years period. They don't have much signs and symptoms. Then, now the person is now okay, looks okay because he's having the infection in his body, but he doesn't know about it. Okay, he's not symptomatic also. What happens? The disease is a silent killer. Afterward, this can progress into what is called, this is also secondary syphilis. You can see everywhere you have this rash. Then after about 2 years, you will get, some people will go into what is called tertiary syphilis. Tertiary syphilis. That is the third stage. Tertiary syphilis. Now, this is the most dangerous part. Tertiary syphilis. When somebody has gone into tertiary syphilis stage, they can get 2 main complications: cardiovascular complications and neurological complications. When it comes to the cardiovascular system, in your pathology knowledge, I'm not going to ask what pathology, Sajana, right? So in your pathology, you would have heard about aneurysms, aortic aneurysms. You get the aortic aneurysm in the descending aorta or the abdominal aorta, or like that in the lower part of the aorta usually. But in syphilis, tertiary syphilis, you can get aortic root aneurysms. Just at the beginning of the aorta beginnings, you know, from the left ventricle, the aorta begins, right? Right at that point, you can get aortic root aneurysms. It is rare otherwise, but with tertiary syphilis, you can get it. So, what is an aneurysm, Darwani? Aneurysm is the dilated vessel, focal dilatation of the vessel. So, right, this is the left ventricle. This is where the aorta usually begins, right? In aneurysm, you will get a dilated focal dilatation of the vessels. So when the vessel is dilated like this, it's very weak, and because of the pressure, it can rupture. If the aneurysm ruptures, you can think about the amount of bleeding he or she can have, because it starts from the aortic root. Massive bleeding, sudden death. This is one of the dangerous complications of tertiary syphilis, aortic root aneurysms. That is the cardiovascular complications. So you can get aneurysms in anywhere else also, but this is the major part. When it comes to the neurosyphilis, their nervous system can be affected. So they can get a lot of deformities and all. Walking, their gait will be unstable, right? Their spinal cord can be affected. Their higher centers can be affected. Okay, so likewise, they can sensorineural hearing defects. Right? So a lot of neurological complications they can get. So when it comes to syphilis, it's a spirochete caused by a spirochete larger than a bacteria, right? You have several disease stages: primary, secondary, latent, and tertiary syphilis. Primary syphilis is up to 6 weeks, characterized by chancre, single painless ulcer, highly infectious. When it comes to secondary stage, you can get condylomata lata everywhere in your body up to about 6 months. After some time, people can go into what you call latent syphilis, which is a dormant state. And after that, some people can go into tertiary syphilis. Tertiary syphilis, you can get cardiovascular complications and neurological complications. All these things are MCQ points, what I have told you so far. Every single word came out from my mouth at this point, right? All are MCQs. Okay, right. So that is tertiary syphilis. And not only that, Dargo, there's a thing called transplacental transmission. What do you mean by transplacental transmission of an infection? That means when a pregnant mother gets the infection, that can transmit to the baby via the placenta. Through the placenta, usually you all know that placenta is like a barrier. It covers any harmful thing going into the baby. But this spirochete, Treponema pallidum, can cross the placenta and can go into the baby. That's called transplacental transmission. So if a mother during pregnancy gets syphilis infection, that can transmit to the baby. Okay, Shalindra? Baby can be infected in utero, inside. So at the time of delivery, what will happen to the baby? Baby can get what is called congenital syphilis. Congenital syphilis. In congenital syphilis, you can see this characteristic teeth pattern. Okay, this is called Hutchinson's teeth. You can see like these curved teeth, right? So these babies, they can't smile. Why? They can't smile in front of a doctor or in front of a ERPM student, because you all know that the mother got syphilis while the baby was inside. This is characteristic. And not only that, when these people born, after some time, their joints can be deformed. So the middle picture is called Chabre shin. The shin, you know the shin, it's like curved and deformed. And the joints become abnormal, so they can get a lot of ulcerations and all. That is called gluten joints. These are all features of congenital syphilis. And in later life, when they become adults, you can see this, like zombic faces. Okay, so this nose, nasal bridge, and the nasal bones, all cartilages will be destroyed, and they can get these deformed faces. These are all features of syphilis. Okay, so it's a very serious infection. Luckily, we will see less number of patients these days because of the awareness and early treatment. What is the treatment of choice for syphilis? It's the good olden days penicillin. Benzyl penicillin is the treatment of choice. Okay, so if you treat in the primary stage or at least in the secondary stage, you can prevent these complications happening. Okay, right? Clear? Right. Sorry. When it comes to the diagnosis, how are you all going to diagnose syphilis? How to diagnose syphilis? Syphilis, if you have this kind of an ulcer, you can take a smear, you can take a swab from the ulcer, and you can do what is called dark ground examination. Dark ground examination. With the dark ground examination, you look it under the microscope. It's a special feature, right? When you do the dark ground microscopy, if you can see this spirochete, Treponema pallidum, then that is diagnostic of syphilis. That is a bedside test. You have to take a swab and do the dark ground examination. There are other immunological tests also you can do to come to a diagnosis of syphilis. Immunological test. Some of the immunological tests are specific, some are non-specific tests. Non-specific and specific tests. One of the non-specific tests is called Kazun, right? One of the, shall all of us take a deep breath? Shall all of us take a deep breath? Okay, no one can't fall asleep during this time. Okay, right. So what are these non-specific tests? Have you all heard of VDRL? Venereal Disease Research Laboratory Test, VDRL. You would have heard of this test. Can somebody tell me, where have you come across this test, VDRL? Anyone? Anyone? Where have you come across this test? All pregnant mothers in Sri Lankan setup, when they are pregnant, at the booking visit means the first visit. At the first visit itself, everybody should undergo this VDRL testing. This is to see whether they are infected with syphilis. Venereal Disease Research Laboratory Test. You don't have to remember the long name. VDRL. So if VDRL is positive, can you say you are having syphilis? Suppose there's a patient coming, Danushika, okay, patient coming, pregnant lady, at the booking visit, you do VDRL test came as positive. Suppose I'm the patient. Can you tell, look, you are having syphilis? Why we have done it? If you can't say this is not syphilis, yes, Netmi. Huh? Yes. As the name implies, it's a non-specific test. Non-specific test. Just because VDRL is positive, Shalindra, you can't say you are having syphilis. You have to do then a more specific test to see whether you are actually having this disease. Because VDRL can be positive in number of other instances. I have given a list in your handout. In leprosy, it might positive. In tuberculosis, it might positive. Sometimes even in pregnancy itself, it can positive. Rheumatoid arthritis, it might positive. So it can give a lot of false positives. So if it is positive, you have to do a then you have to do a more specific test. One is called FTA antibodies, Other one is called TPHA, Treponema pallidum heme agglutination test. I have given the names in your handout, don't worry. Okay, these are more specific tests. Suppose someone is having positive VDRL, you don't tell the patient that you are having syphilis, but you have to refer this patient for a more specific test. Now, suppose the specific test also, Vijita, came as positive, FTA antibodies or TPHA also positive. Then what you can say? Now you can say for sure you are having syphilis. Then you may be wondering at me, so when you have this specific test, why the HELL you are doing this non-specific test? That is that only. This VDRL will be positive. Remember, this VDRL will be positive only if you have the active disease. Once the disease is treated, VDRL is negative. When you have the active disease in your body only, VDRL will become positive, not otherwise. What about this test, specific test? Once you get the infection, even though the infection is well treated and it's under control, it's no longer there, still these specific tests are positive. It's lifelong. That's why, we don't mind whether the patient had syphilis in the past and now it is treated, and if she is asymptomatic and no infection, then we don't mind. Okay. So if you do these tests, they will say still she is positive, but she doesn't have the active disease. That's why we initially do this VDRL. If VDRL positive, there's a possibility of active disease, and then do the more specific test. Vilangada, Sinhala Terrier, English Terrier. Any problem so far? Anything that is not clear about this syphilis?
Transmission, can it happen in any stage, in primary, latent, or secondary and tertiary too?
In primary syphilis only. Primary syphilis only, it is infectious. When you come to the secondary, tertiary, it's not infectious. Infectious means the ability to transmit to another person. Only during primary syphilis, the infection having this feature, infectious. Afterwards, it's not infectious. Is that clear? Yes. So remember, all pregnant mothers in Sri Lanka, in other countries also, some other countries they do, right, have to undergo this VDRL testing at the booking visit. But just because VDRL positive, you don't label the patient as a syphilitic patient. Remember. Okay. Any other question? Good. Anything else you want to know?
So excuse me.
Yeah. Go ahead.
So how to do the treatment? Is it oral or?
Huh?
Is it oral or IV?
No. Benzyl penicillin. Benzyl penicillin is IV penicillin or IV or IM, parenteral route. There are various regimes that you have to follow, right? You have to have a discussion with the microbiologist, and then you have to decide. Then it's not oral penicillin, though, it's the benzyl penicillin. Okay, right? Good. Right. Shall we come to this infection? Now, are you all consultants now regarding syphilis? Yes, you all are. Yes, good. Right. Okay, come to HIV. Right. HIV is caused by a virus. Is it a DNA virus or RNA virus? These are MCQs. RNA virus. HIV is an RNA virus caused by RNA virus. How do you get the HIV transmission? Do you get with the sexual contact? Yes. It's a sexually transmitted infection. How else? How else? Transfusion of blood and blood products. Right? Now, suppose I am having anemia, you give me a blood sample of a HIV positive patient. So I will also get HIV. How? Aparadi. right? Transfusion related. How else? Organ transplantation, right? If you are a renal disease patient, from a donor, you get a kidney, and that donor is positive for HIV. So you will get a free chance to get HIV. Okay, sharing needles and the injectables, especially among drug addicts, you will get HIV. So last month in Sri Lanka, there was a huge ice crisis. Then ice gahanne kawurut chandelanga nisa. Ee dawasala ice gahuwa. Eතකොට with these drugs and drug addicts, among them, you can get this HIV. Okay. Do you get HIV just because you are kissing a patient with HIV? Say, for example, I'm an HIV positive patient. On the video, I'm an HIV positive patient. Somebody comes and kiss me, in the sense, lip kiss. Do that person get HIV? Does that person get HIV? By lip kissing? No. Unless you bite your tongue or something, blood contact, otherwise by kissing, you won't get HIV. Suppose I am having HIV and my neighbor also sitting close by, right? A mosquito comes and bite me and go and bite that normal person. Will that person get HIV? No. No. Still not. Suppose I am having HIV. I am sharing my lunch packet with my bestie. Will that person also get HIV? Sharing foods? No. You are sleeping in the same bed with the HIV person. Sleeping in the same bed with the HIV positive person. Will you get HIV? No. So don't worry about those methods, right? So you will get HIV by sexual contact. Okay. Who does get HIV most? It's the heterosexuals or the homosexuals. More than half of the HIV positive cases are among heterosexuals. Hetero, not the homo. Homo also, there's a chance, but if you take the population, the homosexual population is relatively small. So that's why they have the less number. However, right, statistically, most patients who are HIV positive are heterosexuals. Okay, right. So when you take HIV, there are various subtypes of HIV virus, right? So HIV-1 and HIV-2, those are the two main types. HIV-1 is more commoner than HIV-2. But whatever it is, ultimately the disease is same. What does HIV do actually? Halugamage, Isuru Sampat. What does HIV do, Daru, in your body? Suppose I am HIV, I'm a normal person. Today, I do a naughty things, and HIV virus entered into my body, my bloodstream. What will happen? What will happen? Where do they go and attack? They go and attack your immune system because, you know, in day-to-day practicing, every second, the second I'm talking now, you are getting millions and billions of germs entering into your body. But when you go on a bus, public transport, when you go to a toilet, when you go to somewhere, you get lots of bacteria and viruses entered into your body. But you won't get that infection. Okay, why? What is the reason? When somebody entered into your body, you have an immune system or a very good army, weaponed army, right? So they understand, they identify this foreign thing as foreign and react against the foreign thing and get rid of the thing from the system. They attack the foreign organisms from our immune system. So what does HIV do? HIV entered into your body and go and destroy your immune system. They attack the immune system. They straight away attack to the army of the country. When the army is down, there is no security for the rest of the country. Something like that. Okay, so this HIV virus go and hit on your what is called CD4 cells. CD4, these are kind of lymphocytes, right? Lymphocytes, they go and attack on these lymphocytes. When the lymphocytes are attacked, your immunity goes down. When your immunity goes down, you don't have any protection in your body. Whoever the virus or the germ or the fungus entered into your body can cause a disaster in your body. So typical examples of HIV-related infections are this: pneumocystis pneumonia. Normal people like you and me, suppose we are normal, right? We won't get pneumocystic pneumonia, but when you are HIV infected, you can get pneumocystic pneumonia. Kaposi sarcoma is a skin cancer. Normally you won't see it, but if you are an HIV positive person and immunosuppressed, you can get it. Shingles, we will discuss about shingles later. This is also called herpes zoster. To get herpes zoster, HIV is not only the only thing, but when you have any immunosuppression, you can get shingles. Oral candidiasis, fungal infection in the mouth. You can get candidiasis, we will discuss later, in the vagina, very common. But you won't get oral candidiasis. So today you go in front of your mirror and put your tongue out and see what is the tongue looks like. If the tongue looks like this, you are having Sohon Lakunu, maybe oral candidiasis, maybe a feature of HIV. You will get the same appearance. That is not oral candidiasis, right? You will get this with HIV. Okay, Daruni, right? So what does HIV do in pregnancy? Sorry, what does HIV do in pregnancy? Do they cause abnormalities of the baby like in syphilis? Does the HIV transmit transplacentally? What do I mean by transplacental transmission? From the mother to the placenta, do they go to the baby? Yes, it goes. If a mother is having HIV, what can happen to the baby? Will the baby get deformities? Hutchinson teeth, gluten joints, Shabra shin? Do they get all these abnormalities? No. No. Remember, any infection can cause miscarriages. Yes. HIV also can cause miscarriages. Any infection, remember, any infection can cause miscarriages. So miscarriages can happen. Otherwise, HIV will not cause major impact on the pregnancy. HIV will not cause a major impact on pregnancy. Okay? And vice versa. Pregnancy also will not affect the HIV disease process. They live in harmony usually. Ranil Wickramasinghe, they live in harmony. They don't cause Rajapaksha damage, and Rajapaksha won't cause any damage to Ranil Wickramasinghe. Something like that. HIV and pregnancy is something like that. Okay? No major effects. But HIV can transmit to the baby. That is the problem. Okay? Right. So, main problem with HIV in pregnancy is transplacental or mother to child transmission. You can do three things. You have three strategies to minimize mother to child transmission. Danushika, if the mother is having HIV, if you are not treating her, what is the chance the baby can get HIV? Is it 100%? No. 90%, 75%, 50%, 40%? No. 30% of chance there's a risk that the baby can get HIV. 30%. Still, it's a significant amount. 1/3 of babies can get HIV from the mother. So you have three strategies to minimize this mother to child transmission. What are those? One is that when you have to treat the mother, with what is called heart. You have to treat with heart. Sorry, what do you mean by this heart? Anyone? Anyone? What is heart? Yes, Senuri, what is heart? Vijita, what is heart? Highly active antiretroviral therapy. Highly active anti-retroviral therapy. You know, HIV is also called retroviral therapy. Highly active antiretroviral therapy. It's a combination of drugs. So now do you know that all HIV positive patients, they don't get the treatment? So we monitor HIV positive patient in various ways. One is viral load. How much viruses are having in their blood? It's called viral load. And the CD4 count. CD4 count should, when there's active infection, CD4 count go down. So if the viral count is low and CD4 count is high, everybody listen. You don't have to treat the patient. But all HIV positive patients should be given treatment after 24 weeks, whether they are irrespective of their viral load and CD4 count. All HIV positive patients should get the treatment after 24 weeks to minimize the mother to child transmission. Remember, this is one way to minimize vertical transmission. Okay, Suvini? Suvini Gunasekara? Right. Okay, clear? It's okay. You all can switch on your faces, right? I'm not going to ask difficult questions from you all. I just want to keep this session live. That's all. I mean, because I used to teach students in a live way, in a live classes before I left the country in 2019. So I was one of the I had about 200 students in my classes, 150 to 200 major classes. I used to do live classes, not like these days. Doing these Zoom classes are very boring to me, boring to you all as well. So it's very boring. But at least keep your face a smile. Then it becomes more live. Okay, right. So what are we talking now? Let me. 3 strategies to minimize mother to child transmission. One is treat the mother. Everybody should get the treatment from 24 weeks onwards with heart. Second strategy was do elective cesarean section and deliver the baby. Compared to vaginal delivery, elective cesarean section minimize the chance of mother to child transmission. There are exceptions. I'll come to that point later. Third strategy is avoid breastfeeding to the baby. Avoid breastfeeding to the baby. To the baby, as far as the baby is concerned, mother should not breastfeed the baby. Okay, right? By doing these 3 things, you can minimize. Now, I told you mother to child transmission is about 30%. By doing these 3 things, you can drop it to below 1% if you do these 3 strategies. In the exam, Mohammed Dilshad, in the exam, if they ask a question, what is the single most strategy that you can do in HIV positive mothers to minimize mother to child transmission? Out of these 3 things that were breastfeeding, avoidance of breastfeeding is the single most effective method. Remember, MCQ. I think I have highlighted in your handout also. Okay. If I'm not correct, if I'm correct, right? Just go through your handout. So this is one of the main things that you have to do, avoid breastfeeding. So everybody who is HIV positive should be started on treatment from 24 weeks onwards, irrespective of their viral load and the CD4 count. Should offer elective cesarean section for the delivery and avoid breastfeeding. When it comes to the elective cesarean section, everybody take a deep breath. Listen carefully. Think something interesting. What is interesting? Galbanis, Jnanakatha. Think something like that rather than thinking about ERPM. Right. Okay. Now I'm going to talk about the exceptions regarding this elective cesarean section. Those days when we were students, ඒ කියන්නේ 1800 ගණන් වලද නෑ නෑ මේ ළඟදී අපි ඉච්චර වයස නෑ මෙහෙම හිටියට, right? So when we were student, we were told that all HIV positive patients should undergo cesarean section for the delivery. But now the guideline changed. How do they tell now? Yes. You check the viral load. That is basically the amount of viruses in your body. Viral load at 36 weeks or closer to delivery, 36 weeks. If it is below 50, whether you undergo a vaginal delivery or a cesarean section, there is no significant difference. That means if the viral load is below 50, they can have a vaginal delivery. Remember, these are SBs. So if MCQ says all HIV positive patients should undergo cesarean section for the delivery, wrong. If the viral load is below 50 and CD4 count is more than 350, then they can have safely a vaginal delivery. In other words, this patient having a good disease control. That is one thing. Okay. If the viral load is more than 50, better to deliver by a cesarean section. Or if the CD4 count is less than 350, better delivered by a cesarean section. Is that clear? Clear to y'all? Okay. Second thing. Some people used to get heart means a combination of treatment. There's another drug called zidovudine. Some people instead of heart are on zidovudine monotherapy. Monotherapy means only zidovudine is given. Zidovudine monotherapy. These people definitely should undergo cesarean section irrespective of the viral load. If you are on zidovudine monotherapy. Zidovudine. I have given the names and the details in your handout. Don't worry, right? If somebody is on zidovudine monotherapy, these are MCQs, they have to undergo a cesarean section for the delivery. But those who are on polytherapy, that is hard, and viral load is below 50, they can have vaginal delivery. They can have a vaginal delivery. And all HIV positive mothers, soon after delivery, baby should be started on the antiretroviral therapy. Within 4 hours, you have to start the baby on antiretroviral therapy. And serially, you have to check their virus status in serial. I have given the time frame in the handout. Go through it. So you do the last screening at 18 months. If everything is negative, you can say baby is not infected with HIV. Is that clear? Any problems so far? Are you all okay with HIV infection?
Excuse me, sir.
Yes,
sir. If CD4 count is more than 350, we can go for vaginal delivery, right?
If CD4 count, both criteria should be fulfilled. CD4 count more than 350 and viral load less than 50. Yes.
Both parameters.
Both parameters, both criteria should be fulfilled.
Okay. Thank you.
Okay, right. Any other question? A question එකත් අර question එකත් තවත් question තිබේද? Anything else before I move on to the next topic? Okay, clear? Clear. Right. So we have discussed 2 important topics, infections. One is syphilis, one is this thing, that is HIV. Okay, so now Darwani, before you forget these things, I think now suppose I have talked to you about 100 things. By now, you may be having about 60-70% in your brain now. If you recap these things within 2-3 days time, then it will be like almost 100%. Okay, so when you go home, when you have a leisure time, right? WhatsApp again, lecture note open, just have a look. How does HIV poses problem and what are the treatment options and all? Okay, now how does HIV is diagnosed? I'm not quite sure, but I have given that in your note. How does HIV is diagnosed? There's HIV rapid test that is called ELISA. HIV ELISA. HIV ELISA. Please jot it down in your handout, right? HIV ELISA. It's a rapid test. ELISA. HIV ELISA. This is also like VDRL. Just because ELISA is positive, you don't tell that patient you are HIV patient. Then you have to do more specific and more advanced test that is called Western blot. Western blot is the diagnostic test for HIV. Western blot. Remember those points as well. Okay. Prashanya. Are you okay, Daru? Okay, the kilo anything. All right. Now come to the next infection that we are going to discuss. Hepatitis B. Hepatitis B. Okay, Utbala? Right. Now we are going to discuss about hepatitis B. Hepatitis is a series of hepatitis viruses. These are viruses, right? Series of viruses. Hepatitis A, you have hepatitis B, hepatitis C, hepatitis E. Likewise, there are various subtypes. We are going to talk about hepatitis B. Again, this is a DNA virus. Remember, hepatitis A, that's the normal, the kahauna in Sinhala, I don't know the Tamil word, I'm sorry, right? Kahauna, the normal hepatitis that you can get with as a gastroenteritis is hepatitis A, right? Hepatitis A. Sometimes as outbreaks you get in India, in Pakistan, Nepal, and other countries, you get outbreaks. That is hepatitis A. It's a RNA virus. Hepatitis B is a DNA virus. It's a DNA virus. The incubation period may go up to about 6 months. Right? How does hepatitis B transmitted? Is same as HIV. Sexual contact, blood and blood products, then organ transplantation, sharing needles and the cutting devices and all, right? Drug addicts, the same as HIV. Okay, all right. Remember, any of the infection, whether it's even in HIV, if you have very good immunity, right? If you have good exercise tolerance and if you are having healthy diets, right? In that case, even HIV you can get rid of from your body, because that's why even the mother is having HIV, the chance of baby getting the HIV is about 30%. 70% of cases it won't. So hepatitis B also the same. Once the virus entered into your body, if you have good immunity, most of the cases you can eliminate this infection. Okay, right? Good. When you take this structure of hepatitis B, so you can have a look, Daru. In your handout also it's given. This is the structure of the virus. It's a DNA virus. You can see there is an outer surface capsule like thing, like rings, outer layer, right? It's kind of a capsule. And there you have very important antigen or a protein that is called hepatitis B surface antigen, HBsAg in your picture. Okay, surface, on the surface, there's a surface antigen. And inside, Dargo, you have another, now if I draw it here, right? The outer layer, the outer shell, you have hepatitis B, surface antigen. Inside, you have another antigen that's called hepatitis B, E antigen. It's inside E antigen. And inside, further inside, you have the DNA molecule inside, nucleus. Right? Remember about these details. You have surface antigen there, E antigen is inside, and you have the DNA molecule towards the center. This is the structure of hepatitis B. What is the one which causes the disease in humans? It is this protein. This is the surface antigen is the one which causes the problem. Okay. So if you now say, for example, forget about hepatitis B, when someone get an infection, suppose corona enters into your body, Utpala. Now, via the Zoom, you get corona entered into your body. What happened to your body? Your body's immune system will identify this is corona and they will produce antibodies. What is the first antibody to be produced in any of the infection? You know the antibodies, right? The good olden days are what antibody you get? IgM. Initial infection, you will get what is called IgM antibodies. It may be hepatitis, it may be corona, it may be HIV, it may be anything. Any infection is entered into your body. Within a short period of time, you produce IgM antibodies. And it is not long lasting. After some time, the level drops. When the levels start dropping, you develop another antibody that is called IgG. This is IgM. This is called IgG. What is the difference? Everybody have a look. Look at this graph. Can you all see this graph on the board? Maybe a bit shiny. I'm sorry about that thing, right? Now, this IgM is the initial antibody response. It is short lasting. Whereas IgG, it's slower to begin, but the effect is long lasting. Maybe sometimes lifelong in some of the infections. IgG. Okay. All right. So now, having this knowledge in your mind, we'll move on to hepatitis B. Everybody, take a deep breath. Stop thinking about your girlfriends, ex-girlfriends, and future girlfriends. Think about hepatitis B now. Hepatitis B, NetMe, is a DNA virus. Okay, it's a DNA virus, right? So this is the structure. On the outer shell, you have the surface antigen. That is the most dangerous antigen. And inside you have E antigen and the DNA. When the virus entered into your body, you will develop IgM antibodies. That is important for in a short run. It is not long lasting. And after that, you will get more strong and more steady and more long lasting IgG antibody response. Okay. So when you take a sample of blood, now when you are going to leave the country, most of you will be leaving the country now in near future. All right. And it becomes you will be leaving the country now, right? So before you leave the country, they will ask for your hepatitis B status. You check your blood. If everybody listen, if your hepatitis B surface antigen positive means what? You are having the active hepatitis B infection. In your blood, if your hepatitis B surface antigen positive means you are having the disease. IELTS pass or not, you will not be taken into those countries. Okay. If you have hepatitis B surface antigen positive, E antigen positive. E antigen positive. Dekama positive. What does that mean? Mohammed, Dilshad, what does that mean, Daru? Surface antigen also positive, E antigen also positive. What does that mean? You are having the disease, not only that, you are highly infectious. Highly infectious. But highly infectious. E antigen positive. Okay, you have to be worried a lot. On the other hand, Daru, hepatitis B surface antigen negative. However, hepatitis B surface antibody positive in your blood. What does that mean? Antigen negative, but surface antibody positive. What does that mean? Somebody think.
Immune.
Huh?
You develop immunity.
You have the immunity. Very good. Either you got the infection long time ago and recovered and you are having the immunity, or you had your vaccine. After the hepatitis B vaccination, you will develop antibodies in your body. So you are protective. You don't have to be worried about hepatitis B now. Is that clear? So in the exam, Daro, please read your question carefully. Whether they are asking about the surface antigen or they are asking about the surface antibody. If the antibody is there, you are immune. If the antigen is there, you are infectious. Is that clear? Is that clear? So some of the students in the exam, they come and tell us, easy peasy paper was asking about hepatitis B. But unless you are really careful enough, you can easily go wrong. Because in the exam, your higher centers are not working most of the time. Your spinal reflexes are working because of the stress. So unless you have a solid theory knowledge, you can go miss. You can easily go wrong, right? So please read your question carefully in the exam and see whether they have asked about antigen or the antibody. Okay. Right. Suppose, come to the pregnancy, hepatitis B and pregnancy. Mother is having hepatitis. Now, before that, Daru, what are the problems of hepatitis B? What are the problems of hepatitis B? Hepatitis B can persist in your body more than 6 months period. That is called chronic carrier states. Chronic carrier states. Chronic carrier states. What else it can cause? Hepatitis, as name implies, it affects your hepatocytes, liver. It can cause acute hepatitis, chronic hepatitis, cirrhosis, and hepatocellular carcinoma. Hepatocellular carcinoma. In a single picture, all the disease stages are given. It can cause acute hepatitis, chronic hepatitis, cirrhosis, hepatocellular carcinoma. Those are the two complications of hepatitis B. Chronic carrier states as well as these complications. How to diagnose? By blood, that is serology. See whether the surface antigen is there or the surface antibody is there. How does hepatitis B transmitted? Same as HIV. Is it a DNA virus or RNA virus, Kasun? It's a DNA virus. HIV is RNA virus. Hepatitis B is a DNA virus. Right. Come to pregnancy. A pregnant mother having hepatitis B, surface antigen positive. Hepatitis B antigen positive. What can happen to the baby? Can they transmit this infection to the baby? Yes, they can. There's a newer drug for hepatitis B as well. Again, this was discovered recently. That is called tenofovir. I have given the name in your handout, tenofovir. Tenofovir is a treatment for hepatitis B virus, antiviral agent. You can give tenofovir during pregnancy to the mother. And not like HIV, Daru. If a mother is having HIV and if the viral count is more than 50, you have to go for a cesarean section for the delivery. But hepatitis B, they don't suggest you need to have a cesarean section. They can have a vaginal delivery. They can have a cesarean section. It's optional. Patient has to choose. But most of the cases, people go for a cesarean section. But hepatitis B per se is not a definitive indication for cesarean section. Can they breastfeed? Yes, they can breastfeed. Breastfeeding also not contraindicated. Okay. And if a mother is having hepatitis B, soon after the delivery, baby should be given immunoglobulin, that is the passive immunity, as well as the vaccine. Active and passive vaccination should be given immediately after delivery to the baby. Active and passive immunization should be given to the baby immediately after the delivery if the mother is positive for hepatitis B. Okay, clear? Is that clear? That is all about hepatitis B. So we have so far discussed about syphilis, we have discussed about HIV, and now we have completed about hepatitis B. Hepatitis B. Any problems so far? Any problems, Naruni? Anyone?
The immediate hepatitis B treatment is needed if the patient is diagnosed of hepatitis B?
Hepatitis C.
B.
Yeah.
Immediate treatment, is it necessary? Like as soon after diagnosis, should we start treatment?
Normally, after the second trimester onwards, you would start the treatment, tenofovir, because most of these drugs, they don't have evidence to say those are safe during the first trimester. So people usually start from the second trimester onwards. Even the heart therapy, they start after 24 weeks, middle of the second trimester, something like that. Okay. Yes. Any other questions? Tirunadu, Naddu. Right? Shall we move on to the next infection? Now you guys may be feeling like you all also having these infections by now. From the time we started, we are talking about infections. Now you may be thinking, oh my God, I am having hepatitis B, now HIV. This thing is not good to have. Herpes. Most of the people have confusion herpes infection with syphilis because they both go like sound similar but totally different. Herpes simplex, it's a DNA virus. Herpes, right? It's a viral infection, it's a DNA virus. So herpes viral infection, there are HSV1 and HSV2, herpes simplex virus 1, herpes simplex virus 2. Usually HSV1 virus type, HSV1 causes oral ulcerations, oral lesions. And herpes, HSV2 usually causes vulval lesions. HSV2 causes vulval lesions and genital lesions in a male, right? But HSV1 causes oral lesions. That's how it is designed by nature. However, even HSV2 can cause oral lesions. don't know the reason. You guys have to discover. What I told was HSV1 usually causes oral ulcers. HSV2 causes genital ulcers. Due to unknown reasons, sometimes even HSV2 can cause oral ulcers and vice versa. So in an MCQ, if they say HSV1 usually causes oral ulcers, yes. HSV2 usually causes genital ulcers, but they can interchange and cause in any place. When it comes to clinical features, Taru, can you remember about the syphilis, the first infection we discussed? So spirochete infection. In primary syphilis or the chancre, they get a single painless ulcer. Single painless ulcer. Single painless ulcer. Can you remember? When it comes to herpes, Darwani, it causes multiple painful ulcers. Everywhere in and around the genital area, multiple painful ulcers. Multiple painful ulcers. Initially, they get these blisters and they breaks and causes multiple ulceration around the genital area. It's so painful, severely painful. You know, the genital areas are very delicate and it's very pain sensitive. When you have multiple ulcers everywhere, right? It's so painful. Females usually present with herpes simplex. When they have the herpes simplex, usually they present with acute retention of urine. They can't pass urine just because of the pain and swelling. If a female comes and tell you about acute retention of urine, one of the possibilities is herpes simplex. Okay. This also transmit skin to skin contact. Not necessarily to be the sexual, but usually sexual, but skin to skin contact. Okay. When you contact with a person who is having this herpes, you can also get the herpes infection. Multiple painful, very painful ulceration, which can cause acute retention of urine. Okay. Now at any age group, this can happen. I have seen lots of young people with this condition. And last week, yes, last Sunday, there was a patient. She was 65 years old, widow, came with pain and acute retention of urine. We had the examination and it was, very full-blown herpes in the genitalia. 65 years old, widow. How to do widow, right? So you can think about the social circumstances and everything. These things, you can't blame the people, but you can see these things commonly. It's a clinical diagnosis. Just by looking at the lesion, you can say this is HSV, herpes. Okay. So even though this is more painful and more, causes ulceration and all, as far as the pregnancy is concerned, when a mother is pregnant, this virus usually does not go through the placenta and cause problem to the baby. Transplacental route is not that common with HSV. But what happened? When the mother is having HSV, Darwani, during the birth passage, when the baby is trying to come out, the baby will be bathing with these secretions. And baby can get through the vagina, transvaginal route. During the birth passage, baby can get this HSV. When a baby gets this HSV, you can see this is a newborn baby with full-born HSV. They can get severe meningoencephalitis, permanent brain damage, or even death. Permanent brain damage or even death. Cerebral palsy, anything can happen with this infection. It's a severe infection to the baby as far as the baby is concerned. When it comes to HSV, are you all hungry? Are you all hungry? No? Right. Good. When it comes to HSV, herpes simplex virus, you have what is called primary HSV and you have secondary HSV. Primary HSV and secondary HSV. These are MCQs. Primary HSV means Darwani. For the first time in your life, when you get HSV, that is called primary HSV. For the first time in your life, when you get HSV, that's called primary HSV. First time, first episode. This is much more painful, much more symptomatic. Primary HSV. What is secondary HSV? These are viral infections. So if you have a good immunity, your immune system can fight against these viruses. And they can put the virus into dormant state. They can damage the viruses. They can attack the viruses. What happens? What happens? This is the brain. This is the spinal cord. You have spinal ganglia here and there. You know the dorsal root ganglia and all in your anatomy knowledge. Anatomy or part of distinction name right? Anatomy knowledge, Vijita, right? And Ungilina Gaman, right? What happens? These are ganglia, right? So these viruses, Darwo, when your immunity is coming up, they go and hide behind these ganglia. They can hide. Aragulakaru inagamang Rajapakshalagila hangin or something like that. They can go and hide here. What happened? Later, once the immunity goes down or due to some reason, they can reactivate and cause the disease again. That is called secondary HSV. That is not symptomatic like primary HSV, but it also can cause the vulval lesions and all like this. Primary HSV means for the first time. Secondary HSV means the reactivation of the disease later. Less symptomatic. Since the primary HSV is more dangerous, in pregnancy, if a mother is having primary HSV with active lesions, active ulcerations, you have to offer elective cesarean section for the delivery. If the mother is having primary HSV with active lesions, you have to offer elective cesarean section to avoid the baby getting contamination. Secondary syphilis, Darwo, the transmitting the infection to the baby is relatively less. So they can have a vaginal delivery or a cesarean section, but it's optional. But primary HSV, if a mother is having primary HSV, and if there are active lesions closer to delivery, you have to offer elective cesarean section. Is that clear? Clear? Are you all sleeping? No. Right? So you have to know about these things with regard to HSV. It's a viral infection, DNA virus. And what are the RNA viruses we have discussed so far? HIV. Your hepatitis B, then HSV, those are DNA viruses. Hepatitis B, HSV, those are DNA viruses. Okay. You want to take 1 minute break? 1 minute off? Take 1 minute break. Boyfriend, girlfriend, message ya kya pulang? WhatsApp message ka dagan pulang. Maya kata mi wala something like that. I will take about half an hour.
Sir,
Yeah.
Can you re-upload the document because I have joined later?
Okay, right. I'll ask Sudhir, right?
Okay.
I think he's also joining at the moment. He will do it again, or else this is Mohammed Dilshad, isn't it? Dilshad.
Yes, sir. I will WhatsApp him. I have his-
Yes. Please send me your message, and I'll send you the Sudhir's number. Okay.
I have his number. I will ask him.
Ah,
Okay,
right. Okay, right. Okay. Okay, 1 minute over. Shall we restart? Okay, Daroni, come back, because we have a limited time, because this is going to be a short class, right? You must be having some other works also to do, right? Please rejoin. Yes. Okay, thank you. Right. Okay. So, right. So in the chats also, I think he had uploaded the next lecture note. Yes. So at the end of this class, please, I know that you all are in a hurry to go back to your other works and all. Please just leave a feedback. The things that I need to, if you think that something need to be improved, or if you think that this person should not do any RPM classes again, this is once for all, something like that. You can give any comment, that's okay. I just try to leave a message or leave a comment. It'll be highly appreciated. Okay. All right. Okay, Daroni. Now we'll be move on to another very important infection as far as exam is concerned, as well as in your real life. Because now you guys, like now you came from abroad, from Russia, from China, from everywhere in the world, right? Now your neighbors and your relatives, everybody will be thinking that now you are fully qualified doctors. So they will bring to you all various clinical scenarios. Mali balanda podak me akkada chicken pox ella mokada karanna them pregnant, what advices you have to give. Okay, polak ehema karuna, best thing is this class, right? You can gain a lot of knowledge regarding chicken pox, because these are very common cases in Sri Lankan setup. All right, okay, now we are going to discuss about chicken pox or varicella, right? This is again a viral infection. It's a DNA virus. It's caused by Varicella zoster is the virus. Okay. Incubation period is about 2 to 3 weeks. That means once you expose to this infection, these germs, they entered in your body and will cause the signs and symptoms within 2 to 3 weeks time. Okay. How does varicella transmit from person to person? How do they transmit? Respiratory droplets. That means when somebody is breathing in and out, you produce a lot of the droplets, right? And the virus will be contained within these droplets. And when this droplet entered into another person, that person can get the disease. That is called respiratory droplets. The corona also the same. It transmits by respiratory droplets. That's why the rapid transmission. Okay, right. So when you get this infection, right, when the virus entered into your body after 2 to 3 weeks, they causes this generalized vesicular skin rash. Generalized vesicular, like fluid, clear fluid inside, blistering skin rash. Okay, this is varicella or chicken pox. If you have a good immunity, after some time, if the immunity is good, your body will fight against this virus and virus will be eliminated from your body. And during that time, your blisters will be broken and the fluid will be coming out and you will get small ulcers everywhere. And these ulcers also will be crusted and after that it will heal, leaving some scars. Some of the scars are permanent, some of the scars are temporary. එතකොට තමයි කෙල්ලගේ මුණේ පොඩ්ඩක් හිනාවක් ආවේ ටෙම්පරරි කිව්වා. සවුත් මුණේ කොහොමද ළමන මාසෙ වෙඩින් එකක් ගන්න. චිකන් පොක්ස් හැදුනොත් එහෙම මානසික ඉන්න එක. Okay, so if you are not pregnant and if you have good immunity, chicken pox is not a big issue, not a big deal. It's self-limiting infection. Self-limiting. I forgot to mention you all regarding the herpes. Is there a treatment for herpes? For syphilis, it is benzyl penicillin. For HIV, is HAART, highly active antiretroviral therapy. For hepatitis B, is tenofovir. I have given the name. And for HSV, it is acyclovir. Acyclovir. Acyclovir is the treatment for HSV. Sorry, I forgot to mention there. You can give the acyclovir to minimize the symptoms. And in HSV, sorry, I come to chickenpox later. In HSV, you have to do another very funny thing. Ask the patient to take a basin of mildly warm water and add a handful of salt into this and dissolve the salt. So it's basically salt water basin. And ask the patient to lift up the clothes and everything and ask her to sit on this basin for about 20 minutes. Because all the ulcers are here, these ulcers should get exposed to this salty water. This is called sitz bath. Sitz bath. This will faster the recovery of those ulcers. Sitz bath. This is especially effective for HSV. So you have to give acyclovir and sitz bath. I'm sorry, I forgot to mention those things. Okay, clear? Right. Sitz bath and acyclovir. When it comes to chickenpox also, the chickenpox will be caused by a separate virus, Varicella virus, but the treatment is acyclovir. Remember, acyclovir is the treatment for the chickenpox as well. Remember, when somebody develops chickenpox, you have to start the treatment acyclovir soon as possible. When 1 or 2 blisters are appearing, you have to start the acyclovir. Then the severity of the illness can be minimized. Once the disease is full-blown, no point of starting the acyclovir. If you're going to start it, it should be soon as possible. Remember, for chickenpox, if you're going to start acyclovir, it should be soon after. That means it should be at the initial stages of the disease. But if you have a good immunity, even without treatment, also these people will recover. In our Sinhala culture, these people used to tell Deyangelede. Why it is called Deyangelede? Which Deya causes? In the MCQs, you might get which Deya causes chickenpox. Because those days, when there were no treatment, people used to, pray for gods and all those things and do things because there were no treatment. Those who recover will recover. Those who will not recover with immunosuppression and all will die, might die. That's called it was the young lady. So because of that, they won't allow you to eat, the fish, the meat, eggs and all because this something like that. But we have to understand these are all viral infections. If you want to combat against these viral infections, you need to have good immunity. For you to have a good immunity, you need to have good diet. So healthy diet is needed for these infections. Remember. Okay, right. So if you have an otherwise normal person having good immunity, even you get chickenpox, it will get rid of from your system by your immunity. But if you are immune suppressed person, like if you are an HIV person getting chickenpox, that can cause meningoencephalitis and all these complications. And chickenpox pneumonia is a very complicated story. Patient can even die. Chickenpox pneumonia. Rare, not common, but high mortality. We discuss about chickenpox in pregnancy. Chickenpox in pregnancy. Baby inside. Everybody listen. This is going to be a hot exam question because recently, in recent past, they haven't questioned about chickenpox. But this time you might get a question from chickenpox. Get ready. Okay, right. Now there's a pregnant mother who is in the first trimester. What do you mean by first trimester, let me? Within the first 12 weeks. Suppose she's 10 weeks of pregnant. She never had chickenpox before in her life. But her neighbor got chickenpox. Neighbor, but you might have a close contact with the neighbor. We don't know. Neighbors, you can get close contact with somebody who got chickenpox now. Or in the exam, you may get a question. There's a pregnant mother who is 10 weeks pregnant. Her elder son got chickenpox from school. And she had a close contact with the child. What is the risk to the mother and to the baby? If a mother gets chickenpox or get exposed to chickenpox, there's a risk she can develop chickenpox. If the mother develops chickenpox within the first trimester, what can happen? This virus can enter into the body, into the baby, and can cause fetal varicella syndrome. Fetal varicella syndrome. Chance is low, it's about 1%, but can get. The baby can get what's called fetal varicella syndrome. Within the first trimester, this is common, but remember, this can happen up to 20 weeks. I'll come to this point later. Okay? Up to 20 weeks, baby can get what is called fetal varicella syndrome. What are the characteristic features of fetal varicella syndrome? These are the characteristic features. Skin scarring. Like Uttar America, South America, South India, something like a map-like skin. Skin scarring. They cause a skin scar, like burn marks, skin scarring. And they can get limb hypoplasia, small limbs, limb hypoplasia. Those are characteristic clinical features of fetal varicella syndrome. Hands up those who are from Kandy. There was a not small, actually, he was an adult that time. When we were students, there was a person in the Kandy birth station, right, with fetal varicella syndrome. Right, because with limb hypoplasia, his limbs are like this, with skin scarring everywhere. That can happen up to about 1% of cases within the first trimester, but it may occur up to 20 weeks. So this is the most dangerous time for a pregnant mother to get chickenpox. Other thing is, there's another complication can happen that is called neonatal varicella syndrome. This is also called congenital varicella syndrome. This happens if a mother develops chickenpox closer to delivery. Closer to delivery. Say after 35 weeks, 36 weeks, 37 weeks, 38, 39 weeks, if a mother develops chickenpox, there's a possibility baby can get neonatal varicella or congenital varicella. There, the baby will not develop these complications, these deformities and all. Why? Can somebody give me an answer? Why the baby will not develop these abnormalities? What is the reason?
Because the baby is already big, already developed.
Exactly. Already the baby's organs are developed, limbs are developed, right? Skin is developed. So baby will not get those deformities. Instead, what the baby can get? Severe meningoencephalitis. It can cause permanent brain damage. You may get additional parliamentarian, permanent brain damage. Something like that, or even death. meningoencephalitis. Okay, right? That is neonatal varicella. That occurs closer to delivery. So there are two complications can happen with chickenpox: fetal varicella syndrome, that is up to about 20 weeks, and congenital or neonatal varicella closer to delivery. So after 20 weeks, there's a gap, there's a window. After 20 weeks, up to about 33, 34 weeks, if a mother develops chickenpox, what happened to the baby? What happened to the baby? After 20 weeks, if a mother develops chickenpox, what happened to the baby? Baby will be fine. Baby will not get fetal varicella syndrome or neither congenital varicella syndrome. Baby will be fine. I'm pregnant now, I'm 25 weeks. My husband got chickenpox, or my boyfriend got chickenpox. What should I do now? Don't worry, Aki, your baby will be fine. Okay, right? So after 20 weeks, up to about 32, 33 weeks, there is hardly any effect to the baby as far as the chickenpox is concerned. As far as the baby is concerned, there is no effect to the baby. Okay. Is there a vaccine to prevent chickenpox? Is there a vaccine? Yes, there is a vaccine available in the private sector. What kind of a vaccine it is? It's a live attenuated vaccine. So can you give live vaccines during pregnancy? No. So you can't give the vaccine during pregnancy. Okay. Now, when you get chickenpox for the first time, what happened? I told you, if you have good immunity, your immunity will fight against the virus and the virus will be get rid of from the system. And like HSV, these cunning viruses, they go and hide behind those basal ganglia. I told you, basal ganglia, right? They go and hide behind the basal ganglia. Okay, they are within the basal ganglia. They go and hide behind the basal ganglia. And this is the brain and this is the spinal cord. These are the basal ganglia. Like this. Later on in your life, if your immunity drops, maybe due to diabetes, maybe because of steroid therapy, maybe because of organ transplant, maybe because of HIV, for anything, if your immunity drops, what happens? These organisms in the basal ganglia, they can activate, reactivate, and they can cause the lesion. Same disease like chickenpox, but along that dermatome. Suppose, what is this dermatome here? Surgery. What is this dermatome here? Shoulder tip, C4. Suppose C4 basal ganglia activated, you will get the lesions around the shoulder. It's not a generalized disease, it's only along that dermatome. If you get the activation around T10 level, around the umbilicus, you will get the lesions, vesicles along that dermatome. If your lesions on the ophthalmic, along the ophthalmic division, you can get the lesions. Something like that. This is called Can you all hear me now? Yeah. So can you see these shared pictures? Right? Okay. Okay.
Yes, yes, sir.
Can you all see me now? Can you all hear me now?
Yes, sir.
I think there was some problem with the connection. Okay. So hope you all can at least manage at a level of managing the thing. Okay. So this is called herpes zoster or shingles. Shingles mean the same chickenpox virus, same lesions, but only along one dermatome. That is because of this reactivation in the basal ganglia. Okay, Daru, is that clear? Clear there? Yes. Can you all hear me? Good. Right. Now suppose there is a patient with shingles or the herpes zoster. Suppose my friend having shingles. I was never had chickenpox in my life. I am getting contact with him. Okay. So will I get shingles? It's a question that you need to think. The question is, my partner, my somebody friend got not the chickenpox, it's the shingles, herpes zoster. I am having contact with him. Will I get chickenpox or shingles? I never had chickenpox in my life. So if you get exposed, if you are non-immune, you will get chickenpox, not the shingles. Shingles you will get as a reactivation. For that, you need to have chickenpox in the past. But if this is the first time, you will get not the shingles, it's the chickenpox. If that is not clear, please clarify your doubts. Vijita, is everything okay? Is
Yes.
that clear? Okay, right.
Yeah.
Yeah. All right. So please remember about these points, Darwani. Okay, Utpala. Now I am going to discuss with you all regarding the pregnancy. Now we have discussed the microbiological part of chickenpox. There is a DNA virus. Okay, it's a DNA virus, and then it's a DNA virus again. Then the incubation period is about 2 to 3 weeks. When it comes to clinical features, in a non-pregnant state, it will not cause much problems. It's a self-limiting infection. Acyclovir should be started early as possible. And in pregnancy, you can get 2 complications, that is fetal varicella syndrome, about 1% of cases, fetal varicella syndrome, and you can get neonatal varicella. Those are the 2 main complications in pregnancy. Fetal varicella syndrome occurs after about 20 weeks. Then the neonatal varicella happens closer to delivery. So after 20 weeks, up to about 32, 33 weeks, even though the mother gets chickenpox, hardly any effect to the baby. Okay, clear? Right. And usually, Daru, chickenpox immunity is lifelong. That means once you get it, is lifelong because of the IgG antibody response. However, if your antibody levels drops, you can get the disease again, or you can get the shingles reactivation. All right. Okay. Now I'm going to discuss with you all regarding the important facts as far as the exam is concerned. Everybody listen. These are SPS, hot SPS, hot SPS. Right. Several scenarios. Suppose I am pregnant now, right? Suppose I am 12 weeks pregnant. Okay. I never had chickenpox in my life, but one of my close family member having active chickenpox now. How can what are the measures that I can take for the prevention of the disease? Because I'm at 12 weeks, I'm at risk of getting fetal varicella syndrome in case. I'm not immune. I got a contact with a person who is having chickenpox. How can I be protected? Yes. Can you give the vaccine? Why not make me? Vaccine is a live attenuated vaccine. Live vaccines you can't give during pregnancy. It's out. How else? Other ways, Badaro, you can give varicella zoster immunoglobulins. Varicella zoster immunoglobulins. Those who had exposure by giving varicella zoster immunoglobulin, you can prevent the disease occurrence. Remember, you can avoid the risk, or you can minimize the risk of getting varicella by giving zoster immunoglobulins. That is one scenario. So you may get a question in the exam like that. A non-immune person pregnant exposed to chickenpox, how you can prevent? Only way is by zoster immunoglobulin. That's a simple way. Another thing. Suppose there's a pregnant mother who is say 39 weeks now, very closer to delivery. Okay, closer to delivery. She's 39 weeks, never had chickenpox before. Now she's having chickenpox. What is the risk to the baby? Lasita na kumbura. Sorry. Lasita, yes, what is the risk to the baby? Now she is 39 weeks, Daru. Got chickenpox for the first time. What is the risk to the baby? Can the baby get fetal varicella syndrome, Danushika? No. Baby won't get fetal varicella because it is up to 20 weeks. Now she is 39 weeks. What is the complication that you are going to anticipate to the baby? Neonatal varicella. So what you can do? Baby is still inside, closer to delivery, but they got chickenpox. What you can do? You try to postpone the delivery at least for 1 more week. 1 week, you are going to postpone the delivery. Say, for example, you initially plan for induction of labor. We will discuss about this induction and all later in detail. You plan, okay, we are going to deliver this baby by tomorrow or day after tomorrow, we are going to deliver the baby. But today, mother got chickenpox. What you can do? Rather going for a delivery, you wait for 1 more week. You don't allow the baby to be delivered, or you are not delivering this baby within 1 week. Why you want to borrow this 1 week period? Why you want to take this 1 week period? Ruvani, Fayaza, why do you want to borrow 1 week?
So to get antibodies.
Exactly. Who's this brilliant boy? Can't see the name. Usually boys are not talking, but in this class, boys are very active. I'm so proud of myself. Right? Because that's how the boy should be. Right? Okay. The reason is that if you wait 1 more week, during that time, mother will produce antibodies by herself. And those antibodies will cross the placenta and go to the baby and cover the baby. So baby will be protected by the maternal antibodies. That's why you postpone the delivery for 1 week. You postpone the delivery by 1 week. Is that clear? Is that clear? Now, the story is going to be complicated further. Mother was not immune before. Mother was not immune before. And she developed closer to delivery. She developed chickenpox. What you have to do, you try to postpone the delivery for 1 week. So tomorrow was her delivery date. We wait 1 more week further. And day after tomorrow, she's going into spontaneous labor. Membrane ruptured and she's getting pains. And she has now gone into spontaneous onset of labor. Once a patient has gone into labor, natural labor, it's very difficult to stop the labor. Sakkarayata bෑ, Sakkaraya පුතා වයිමාවටවත් බෑ. You can't stop that labor when she has gone into labor by herself. Now she has gone into labor and she is delivering on the second day. She is delivering. Now what can be done? Mother is having active chickenpox. We wanted her to be postpone her delivery 1 week, but she went into spontaneous labor. What you can do? Immediately after delivery, baby should be given varicella zoster immunoglobulins. Baby should be given varicella zoster immunoglobulins. So far, I have discussed 2 scenarios with you. One is mother is not yet developed the disease, right? She is non-immune, but she got an significant exposure to a chickenpox person. What you can do? Give varicella zoster immunoglobulin for the mother for the prevention. Second scenario is she is now closer to delivery. Develop chickenpox. What you have to do? Wait for 1 more week. Don't induce the labor. You wait for 1 more week for the antibodies to produce. But unfortunately, she went into spontaneous labor and delivered before 1 week is over. So what you can do, immediately after delivery, baby should be given varicella zoster immunoglobulins. Varicella zoster immunoglobulins. Okay, clear? Is that clear? Are you all confused now? I think some of you may be confused now. I'm going to confuse you all further now. How? Now listen, everyone, you need to pay 100% attention on this case, right? I don't mind whether you were slept or not, but this part, these 2 minutes, you had to be fully 100% awake. Not only your body, your mind also. Right. The third scenario I'm going to tell you. The mother was perfectly well. She was not immune for the chickenpox, and she didn't have any chickenpox features. In a normal way, she delivered. The baby was delivered today. Okay. On the 3rd day, suppose the first day, 2nd day, 3rd day, 4th day, 5th day, 6th day, 7th day, 8th day, like that. Okay. This is postpartum. Day 2nd or day 3rd, mother is now showing the features of chickenpox. That means the rashes, mild fever, and the vesicular rashes developing everywhere in the body. This is on the 3rd day, or maybe the 4th day, or maybe 5th day after delivery. Now, is her baby at risk? Baby already delivered. By the time the baby was delivered, mother never had any chickenpox features. Now 3 days gone, mother is developing now chickenpox. This is the part you need to understand. Is this baby having a risk of chickenpox?
Yes.
Yeah. How?
Yes. Because the incubation period is 2 to 3 weeks.
Exactly. You are a brilliant student, Dilshad. Right? That's how you need to think, right? Even though mother is showing clinical features now, this virus would have entered her body 2 to 3 weeks before. That means during that time, baby was inside her tummy. Definitely this virus could have entered into the baby also at that time. So baby is at risk even though the baby was delivered. What you have to do now? If the mother develops chickenpox symptoms within the 7 days of delivery, you have to again give varicella zoster immunoglobulins. Zoster immunoglobulins. Zoster immunoglobulins. Okay, Daruni. So please remember about these 3 scenarios. These are the scenarios that you will see in the exam as SPAs. One thing is, mother is not immune, she's pregnant, she get exposed to chickenpox. What to do? You sustain immunoglobulin for the prevention. Second scenario, mother is closer to delivery, develop chickenpox. She developed chickenpox, she's closer to delivery. So what you have to do? You try to postpone the delivery for 1 week for the antibodies you give some time for the antibodies to produce. After 7 days, if you are delivering, there is no problem to the baby. You don't have to give immunoglobulins to the baby. Third thing, even though you plan to deliver after 7 days, mother going into spontaneous labor within 7 days, what you have to do? Immediately after delivery, baby should be given varicella zoster immunoglobulins. The last scenario, mother was completely well before she delivered. At the time of delivery, she was completely asymptomatic. However, within 7 days, if the mother developed chickenpox, again, you have to give varicella zoster immunoglobulin to the baby because this virus would have acquired well before her delivery while the baby was inside. That's all about chickenpox that you have to know. Right? So, with regard to infections, there are a lot of infections that you have to know. But most of the infections are minor things that I have given in detail in your handout. What are the important things you have to remember? Just read them. And if you'll have doubt, you can always contact me. My contact number is given on the top in your handout. Okay. So the crucial ones or the critical ones or the most important one and most complicated ones I have discussed. We have discussed about syphilis. There are stages of the disease, how they spread, what is the treatment, how are you going to diagnose, what is VDRL, and what is the treatment modality. Then we discuss about hepatitis B, we discuss in detail. Then their immunology, what is antigen, what is antibody, and all these things we have discussed. Then we discuss HIV. We discuss about HSV, herpes simplex. We discuss about, especially I wanted to discuss this chickenpox business because sometimes this is confusing. Okay, I hope you had a very good knowledge and your doubt would have been cleared with this lecture. Okay, so since this is meant to be a small class, I drag up to 2 hours. I'm sorry, I was planning to cover within 1.5 hours, but it's difficult because it's a fairly big topic, right? So what you can do is just take your time. It doesn't matter whether you come to my classes or not. It doesn't matter, right? Just make use of this handout, go through it. And if you all have any doubt, you can always contact me. But please remember, infection is one of the major part when it comes to your exam, ERPM. So you need to have a very thorough knowledge. And thank you so much for joining today. And I'm planning to do several more free sessions for you all, right? So if you all want to join with the full course, you can contact Sudhir, and it's in the group. It's his contact details. You can contact him and get enrolled with the classes. The people who are joining, I will make sure that before you go to the exam, I will teach everything in a simplified way and in a practical way for you all to remember for your exam, right? I'll do my part 100%. You also have to do your part. Then it's a combined journey. You all can pass the exam. So again, thank you so much. And please leave a comment at the end of this session. What do you think? Your real idea about the class and the way I'm teaching. And we'll meet up in another discussion like this in a short class, right? In near future, and we will inform you all through the WhatsApp groups. Thank you so much again. Have a nice day and take care.